Hello there and good afternoon. Welcome back to your antenatal education programme. We today are going to be talking about the first stage of labour all the way up until transition, which we shall talk to you about. On Friday, we covered the latent phase of labour, which is all about the early stage of labour. And if you didn't manage to catch that video, you can have a little look back on the page, on the Broadlands page, and you can look that up and re-watch it. So today we're going to be starting off with Laura. Laura's going to be talking about the beginning of the first stage of labour, calling the labour line, what number you need to phone, your journey to hospital and your initial assessment in labour. She'll also be talking about what to do when your waters break. And then Heather is going to go on to talk about labour care and positions in labour and monitoring your baby during labour. And then I shall then go on to talk about pain relief and the different types of pain relief options you have, depending on where you are in the hospital or at home or at the birth centre. So over to Laura.
Hi guys, thanks for tuning in to watch this episode about the first stage. So as Amy said, I'm going to sort of start it off talking about that time when you need to think about ringing the labour line, and then the ongoing assessments from there onwards. So I'm going to bring up the screen now to share with you all. Now, just want to sort of think back now to the latent phase, just because it's going to be important when talking about when to call labour line. So latent phase, as Amy said, is the early stage of labour when your body's warming up, getting things ready to move on to the active stage. It can last for a varying amount of time, and for different women, it can last for varying amounts of hours or maybe even days. It's really important during that stage to use coping mechanisms and distractions to get you through that time. And it is often recognised by the lower pain in your back and in your abdomen starting, like a period pain, and then your mucus show and or diarrhea and vomiting. So then, the first stage of labour is when you're in active labour. So that's when it changes from being irregular painful tightenings to regular painful contractions. So the really important thing for you guys to know is that when you think your tightenings have changed to contractions and they're coming every 2 minutes and they're lasting a good 60 seconds, that is the time in which you're bridging over into the established phase of labour. And that is when it's a really good time to call the labour line. Now, that's not the only reason you should call the labour line. Labour line is also there for any advice that you may need. So if you're not sure where you are in labour, you can always just ring them and they'll have a chat with you over the phone to sort of try and determine where you're at. But another really good sign of labour that you need to call labour line about is your waters breaking. Now, we call this spontaneous rupture of membranes, and that is when the bag of fluids around your baby breaks and starts to let water out. Now, when your waters break, it can either be a big gush of water like you see in movies and TV shows, but actually, more commonly, it's more like a little trickle. So it happens maybe just all of a sudden, and then you don't get anything else for a few moments, and you're just not sure if it's your waters or if it was urine or what it was. So it's a really good idea if either you have a gush or a trickle, the first thing you do is put on a pad so that you can catch any further fluid that's going to come out. Now, once you see that fluid, it's really important to note the colour of it and what time you think your water's broke, because they're the key pieces of information that labour line are going to want to know. Now, the colour is particularly important because if it is green or brown, that may be a sign that baby's done its first meconium poo. And if that is the case, we would then recommend that you are on the labour ward, because that is a risk to baby, and we need to do sort of more continuous monitoring of baby during labour and after baby has been born. But the most important thing for you guys to know is that you call the labour line when you're contracting strongly and regularly every 2 minutes, lasting a good 60 seconds, or when your waters break, noting the time, the colour, and putting on a pad. And we do well, I definitely recommend to my ladies is if you have any pads you had on at the time, put them in a sandwich bag and bring them with you, because we would much rather see it and have a look at it ourselves, because then we can definitely try and determine if it was your waters or not. And we're very used to seeing that kind of thing. So yeah, please don't be embarrassed about that. Or yeah, just call them for any advice if you need it. Now, you can see that I've written as well to please call the day assessment unit if you have any of these sort of more abnormal signs in labour, which are reduced fetal movements, fresh red vaginal bleeding, or constant abdominal pain. So, labour assessment then. You've called the labour line because you think you're contracting 4 and 10 minutes. They're really strong now, they're really regular. Things have definitely ramped up since the latent phase. And the labour line are going to run through lots of different questions with you to make sure you're still safe to go to the birth area which you decided at your 36-week appointment. And then they're going to send you into that birthplace if they think it's appropriate. So, for example, if you were to come and see me, if I was working on, say, Broadlands ward and that's where you wanted to come, I would greet you and then I would start your first labour assessment. So what that labour assessment looks like is I'm going to want to hear the whole story. I'm going to ask you lots of questions to make sure that you and your baby are safe and well. So I'm going to ask you all about what the journey of your labour has been so far. I'm going to have a little look at your antenatal notes. So as Heather said last time, please, please, please bring your notes with you so I can have a look at what's been going on in your pregnancy. I'm going to ask you about if your waters are broken or not. I'm going to ask you if you've had any ask you about your baby's movements. Is there anything that you're particularly concerned about that you wanted to tell me? And then I'm going to start doing some observations. So when we see you antenatally, we do your blood pressure and ask for a urine sample. We're going to do those two things in labour, but we're also going to do a few extra things. So we're going to take your pulse and we're going to check your breathing rate and your temperature. And that is just to look out for any signs of sort of infection, high blood pressure, anything that would warrant a change in birth area. Now, in this current climate as well, we are performing temperatures on birth partners. So just to be aware that that will happen, and we will check birth partners' temperatures throughout labour as well, every 4 hours, just to keep an eye out for any rise in temperature. Now, once we've done those observations and seen that they're all normal, we're then going to have a little feel of your tummies that we normally do, have a measure, have a feel of baby's position, and then have a little listen into baby's heart rate. Now, obviously, what we're looking for is a baby that's head down, for one, and then, as we always do, tell you how engaged your baby is and then tell you what your baby's heart rate is. Now, we normally do that with our sonic aid, which you would have seen that your midwives use in your antenatal appointments. However, some of you may be recommended to have continuous monitoring of baby's heartbeat, and I will show you a picture later on of the CTG machine which is used to do that down on labour ward. So once we've gathered all that information, what I often do is sort of hover around in the corner. I'm sure Heather and Amy do this as well, and we sort of stand in the corner and get a vibe for what's going on. Have a little look at you, look at your behaviour, look at the frequency of your contractions. And then if we think, actually, you're doing really fantastically, your contractions do look like they're every 2 minutes and they look really strong, we may then think that a vaginal examination is going to add information to our decision making. Now, obviously, we understand that this is a very intimate procedure, so we don't want to do them unnecessarily. So we only do it if it's going to add really good information as to whether or not we need to keep you and keep looking after you in labour, or whether it's a case of not quite in the active labour yet, so that we may send you off home again. And that isn't uncommon, especially for first-time mums, that you may come in and have an assessment 1 or 2 times before actually we then start caring for you in active first stage. So vaginal examinations we gather lots of information from them. We don't just look at sort of how dilated your cervix is, we're looking at lots of things. So we're looking at, first of all, your vulva and vagina. So just to make sure that that's all looking all normal, making sure the temperature is nice and normal and not feeling too hot, because we do know that if your waters have been ruptured for a long time, that can slightly increase your risk of infection to baby. so the main aim obviously is to find your cervix, think about where it's positioned in your vagina, how soft it is, its length and how open it is. And we're also looking at what is presenting. So we're hoping that baby is head down when we're looking after you in labour, how far engaged it is into your pelvis and what way baby is facing. So we can gather loads of really great information from a vaginal examination. Obviously, we will then tell you all of our findings and answer any questions you have based on them. So I showed you this picture last time, which is about the effacement, so the cervix softening and shortening. And then this is actually a visual aid as to what your cervix is going to be opening up to. So in the latent phase, it's between 1 and 4 centimetres. It's classed as being in the latent phase. Once you're over 4 centimetres dilated, that is when we class you as well being in the first active stage of labour. So from sort of 4 centimetres and 4 contractions in 10 minutes onwards, that is when we're going to keep you in the birth area that you want to be in, hopefully, if everything is nice and normal, and continue looking after you in labour. So that's a bit about sort of what we'll be doing for you when we're assessing you in labour in your birthplace of choice. Now, I just want to go back to thinking about your rupture of membranes, because sometimes your waters can break before labour starts. Now, the most important thing to know in that instance is that if you're not having any contractions yet, please do phone the labour line and let them know that your waters are broken, so that we know that you're out there. They may then make you an appointment either that night or the next morning to be assessed to make sure that everything is still nice and normal. If your waters have been broken for 24 hours and you have not yet entered labour and you're not yet having regular contractions, then the midwife may have a conversation with you about induction of labour, which we will talk about in our later videos. But just to be clear that your waters can either be a trickle or a gush. They may break before contractions start, or they could break well into the first active stage of labour. And the colour and the time is really, really important. So green or brown may be a sign that baby's done a poo, and clear or pink is a normal colour for your waters to be. So that's a bit about the assessments that we do. I'm going to pass on to Heather now, so she can talk a bit more about the care that we will be providing you once we have established the fact that you are in active labour and we need to continue providing you with one-to-one care in labour in your birthplace.
Lovely, thank you, Laura. Yep, so if you imagine you are potentially in Broadlands or at the New Forest, you've had your initial assessment of labour by the midwife, and for the purposes that we're talking about, let's say that we've examined you and you're 5 centimetres dilated, and we think, great, lovely, let's get the show on the road a little bit. Like we said, Amy's going to talk about the ladder of pain relief. You may have already decided in your birth plan what you would like, what you might like to avoid, or that you're fairly flexible depending on how you are in labour, so how you're actually coping with the level of intensity of your contractions. If you are in any of the birth environments, whether that's New Forest, Broadlands or labour ward, and you are in what we call sort of the established first stage of labour, so past 4 centimetres, you can then start to think about maybe using the pool. When you get into the pool, we do want to make sure that your contractions are still nice and regular. The pool doesn't necessarily stop your contractions, but it can slow them down a little bit to start off with. So we're going to keep an eye on that constantly. The things that we are monitoring in labour, as Laura said, you've had that initial vaginal examination. Especially if your waters have broken, we're not going to want to look to see anything else about your cervix for probably closer to 4 hours. If there's a change in your clinical picture, so if we've got concerns about baby's heartbeat or concerns about maybe some bleeding or anything else, there might be a reason to do it earlier. But at any point, as with any examination, we should always be able to rationalise to you why we would like to do that, what we need to do. So if you don't want that examination, ask us why it's necessary. Is it possible to put it off for a little bit? And if we think it is very important, we know exactly why, we should be able to put our case across to you and explain why. Don't always feel like, well, you're the midwife, you're the doctor, you know better, I'll just do whatever's best. Your opinion, your experience definitely counts. Okay, so when we've done the initial assessment and listened to baby's heart, once you're in established labour, we want to know how baby is coping with your contractions. So when your uterus contracts, it's not only giving baby a bit of a squeeze, it's giving your placenta a bit of a squeeze. And of course, that's baby's main source of oxygenated blood. So once you've finished a contraction, when we listen once every 15 minutes, we will be listening for 1 minute following a contraction, because we want to know that baby is still able to cope with the pressure that's being put on them. So if we don't hear it for long enough, we might listen for a little bit longer. Sometimes your contractions are coming thick and fast, so we might listen for half a minute and then you've gone into a contraction. So we stop, and once that's done, we want to listen again. But we should be listening once every 15 minutes for 1 minute following a contraction. What we're listening for is a nice regular heartbeat, anywhere between about 110, 160, with no deceleration, so no dips in the heartbeat, or ones that do recover quite quickly and quite well. So those are the things that we're looking for when we listen. Later in labour, which we'll talk about in a later video, we listen a bit more frequently. When you're pushing, you listen every 5 minutes, but to start off with, every 15 minutes. You'll notice that we're writing things down in your birth pathway, or if you are having a continuous monitoring, so a CTG, we would be noting that on the computer screen. So you would see us, if you're in labour ward, we've got screens that we call K2, and we're putting all of our findings on that screen so that it's all updated, so we've got a good clinical picture of what is happening. Where next and how established you are in labour, it shows you which sorts of pain relief are available to you. But so you can still have your bath, paracetamol. We've also got things that are slightly stronger, because you might be thinking paracetamol in labour, what on earth is that going to do? Without wanting to get too much into the chemical side of it, but a regular good pain relief, low level pain relief, helps stronger pain relief work a little bit better because of how it interacts in your blood. Okay, the other things that we're going to think about is the position that you're in. Now, there is no right or wrong position. There are only safe and unsafe positions, and ones that are going to help baby come down. Now, if you think about having a bowling ball in your hand, it is going to take more effort to push that bowling ball along a table than if you had that bowling ball and let go of it. So we know that gravity is your friend in labour. We've got lots of different bits of equipment. We've got the birth balls, the circular ones. We've got the peanut balls as well, so the ones that look like little peanuts that you can sit on, rock your hips from side to side. At the birth centre in the New Forest, we've got a really great bit of equipment when your birth partner can sit on the seat, and there's a big bit of material, strong material hanging down. You can kind of hang off that a little bit, or you can sit on the seat yourself, leaning forwards. We've got this kind of zigzag ergonomic chair. People call it different things. If you've had post-states aromatherapy, you may have sat on that so that we can give you the massage. And that's really good as well, because you can kind of lean over the front. When you're having that contraction, you can lift your bum up so that if you're feeling pressure in your bottom or your lower back, that there's a relief there as well. But there are other things in your environment that you can do to help bring this baby down. There are things like, I think Laura's mentioned in the first slide, if baby's back to back, things you might feel that pressure to push a little bit earlier, because the back of your baby's head pushing against your sacrum, the bottom of your spine there, that might make you feel that you really want to. And a lot of women say, I really want to have a poo, because that's the same pressure that you get. So it's ideal really for baby's back to be at your front, so for their spine to be along your bump like that, along your tummy.
Shall I demonstrate? Shall I demonstrate?
Oh, perfect. Yes,
let's
please.
Let's have a demonstration. So I've got the pelvis here, and it's a really good example of how baby should be in the pelvis. Yeah. Okay. So if the baby is in a good position for birth, the baby will be coming down into the pelvis, and the back will be towards the front of the pelvis. Okay, so the baby will go down into the pelvis and have its back towards the front. When the baby is in an OP position, or a back-to-back position, the baby is the other way round. So the baby has gone down into the pelvis, and the back is towards the back of the pelvis. And this is where you'll be feeling lots of pressure, and it can be quite a lot of discomfort in your back. So it's really important to get into those positions that pull the baby's back to the forward, to the front of the pelvis. And I'm sure Heather can talk to you about those positions.
Yeah, absolutely. And we know that that pressure and that discomfort can be quite uncomfortable, and like we said, sort of making you want to push a bit sooner. But baby being back to back is just a different variation of normal. It's easy for baby to come down in that position. I know an amazing midwife who actually has a whole tattoo of a baby back to back because it is just a variation of normal, and it is just a question of trying to get baby's head to tuck. So what Amy will show you on the pelvis in a minute is if baby is having their back at your front like that, it's easy for them to tuck their head under for that smaller part of their head to come down. I'll get Amy to show you that on the pelvis in the dolly a second.
Right.
Lovely. So
go on.
You talk, Amy. Yeah, no, that's fine. I'm not sure if they can see what I can see, so you talk, because I know then they can.
So if the baby is coming down, the baby's head is coming down in the sideways position into your pelvis, hits your pelvic floor muscles and turns slightly, okay? As you're having contractions and the baby is being pushed down, the baby is moving down and the back is towards your tummy, okay? As it's towards your tummy and your contractions are happening, the head is being flexed into a nice position for birth. Okay?
Perfect. So yeah, we'd like baby's head to, like Amy said, to flex, to tuck their chin down, because we want this part of their head, that's the bit that we want to be presenting to come down, because that's the smaller diameter, and that will make it a little bit easier to push this baby down. There are things that you can do in pregnancy, so the later stages of pregnancy and the early stages of labour, to help baby be in that position. If you've got a really nice comfy sofa and you think, oh, I'm just going to lie down, put my feet up and things, try not to slouch when you're in that position, because if you think of baby's back, it's easy for them to turn around and use your spine as a bit of a hammock. That's kind of comfy for them. So if you are sitting, and it's the early stages of labour, try to sit upright or even lean forward. So maybe sitting sort of reverse on a chair so that you can tip yourself forwards a little bit. There is an excellent website called Spinning Babies. So spinningbabies.com will give you lots of different movements, different positions, different actions to try and not only get baby head down, but also to bring babies back to your front. There's lots of partner exercises in that as well. So it's really good to have your partner help you with those first stages of labour as well as the pain relief and the other support, like we talked about in partner support in the first part of the video. But like we said, there isn't a right or wrong position in labour, but the more that you can do to be upright and to be active, it's going to help, because as baby presses on your pelvic floor, what that does is it releases oxytocin. Now, oxytocin is this lovely happy love hormone. You get it when you are eating chocolate, you get it when you orgasm during sex, you get it when you are winning an argument. It's that real exciting kind of like, yes, that real rush of pleasure that you feel. You will also get this rush of pleasure when you lock eyes with your baby for the first time. It's a really amazing evolutionary hormone that's there. But what oxytocin is also responsible for is making your uterus contract. And there's this beautiful kind of cycle. As baby pushes against your pelvic floor and cervical stimulation releases oxytocin into your body. That makes your uterus contract, so the fundus, the top of your uterus, shorten, push your baby onto the pelvic floor, which releases oxytocin, which makes you contract, which pushes your baby onto your pelvic floor. And that's the cycle that we're looking for, those nice regular contractions. So the more upright you can be, the better. We are not going to force you to stand up, to kneel up, to sit on the birth ball. We've said before, those early parts of labour can be quite tiring, so you are more than welcome to rest. But if we think that your contractions have dropped off and they're not quite as regular as 3 to 4 every 10 minutes, we might encourage you to get up and be a bit more active. Another really important part of regular labour care, not only doing your observations, making sure that baby's heart rate is okay. It's keeping your bladder empty, because where baby is just in front of your bladder. So baby is here like this, your bladder is here. If that bladder is full, it's harder for baby to come down. So keeping it nice and empty every sort of hour, 2 hours, just trying to drain your bladder as much as you can, gives baby a clearer pathway to come down. Now, sometimes you don't need to have a drained bladder, but what that can cause is for your bladder to become distended, for it to be pushed out of the way. So we're trying to think about the health of your bladder as well. So all of those times that your midwife talks to you about pelvic floor exercises, really, really important. Every time you think about a pelvic floor exercise, do your pelvic floor exercises. Really good after labour as well, to help maintain your urinary continence and to get the health of your pelvic floor back together as well. So yeah, there are lots of things that you can do in labour to help baby come down. I've talked about listening to baby every 15 minutes. As Laura said, and as we've mentioned before, if there are complications with baby or things start to deviate from where we were expecting them to, continuous monitoring is what we would need to do. So you've probably seen that more often than not when you watch birth on TV, that we've got one pad listening to baby's heartbeat, one pad listening to feeling the contractions, and those elastic straps. Some of you might have even been to our day assessment unit where we're checking if baby's heart rate is okay and what the actions are like, maybe if you've not felt baby move as much. What that is doing is giving us a continuous picture of how baby copes with the contractions. So it's really important that we're monitoring that baby. But again, even if you do need to have that continuous monitoring, it doesn't necessarily mean that you need to be sitting or lying. You can still move around, you can still use the birth ball, because we still want those contractions to come along. When you are having that continuous monitoring, you will notice that a midwife will check every hour. So another midwife will come into the room to do what we call fresh eyes. It's to make sure that we've got somebody else objectively looking at that picture on the screen to notice, not necessarily what we haven't noticed, but to see if they're agreeing with our clinical assessment, because it's always better to get a second opinion. Is this doing what I think it is? Do you think we need to change that a little bit? Because we're looking for different things on there. Baby's regular heartbeat, if they're having any dips, how they're coping with the contractions as well. So don't worry too much if you need to have that continuous monitoring, that you think, right, I'm going to be strapped to the bed now, nothing I can do. You can absolutely get up and around. Pain relief obviously will have an effect on the type of movements that you can do. But Amy's going to talk a little bit more about that. But your established labour, your continual labour, we will do what we need to do. We'll always involve you and explain what we're doing. And if you have any questions as we're going along, please ask us. If you're unsure of the plan, sometimes time is a bit of a fluid concept when you're in that labour room and you think, I don't know how long I've been here or how long I need to wait for my next examination. So please make sure that you and your birth partner are asking all the questions you want to ask. And if you're not sure, just ask again. That's fine. I'm going to hand over to Amy so that she can talk through the pain relief options and a bit further into labour as well. Thanks, Amy.
Thanks, Heather. Okay, so I want to open up this conversation by one phrase. There is no certificate for not having pain relief, okay? You should not feel bad about wanting an epidural. You should not feel under any pressure to do one thing or the other. Now is the time to start thinking about the kinds of things that you would like to use. Most women start off saying, you know, we're really open-minded about the forms of pain relief that we're willing to try. We don't know how it's going to go. Let's just see how it goes. So we have a ladder. I wonder if I can have a look at the ladder, Laura. A ladder of pain relief. And it's a really good way of looking at your options from the bottom, working your way up, okay? I know that on Friday we talked a lot about the bath and the paracetamol and the TENS machine and the dihydrocodeine. These are all the kinds of things that we'd be thinking about in the latent phase of labour or very early on during your first stage of labour. I think we have a picture of the TENS machine as well, don't we, Laura?
Yep.
I just wanted to show you. So this is the TENS machine that we were talking about on Friday. There are 4 pads that stick to your back. They're very sticky. You get a free wax with them as well. Two of them go at the base of your back, and two of them go just slightly higher. And they're attached to this machine, you see. And you press the button as you're having a contraction, and it boosts what feels like it feels like a little electric shocks or pins and needles in your back. It's not an uncomfortable sensation, but it can be a bit awkward to get used to begin with. You can actually start using TENS machines from 37 weeks. So it's usually quite good for just lower back pain at the end of your pregnancy as well. So they're really good. We talked a little bit on Friday about where you can hire them from and where you can buy them. So you can have a little look at that. So if we could go back to the next slide, the other slide, that's fantastic. Okay, so this is where we're starting at the bottom of the ladder. Okay, you're at home, you're in the latent phase or the early stages of your first stage, and you're thinking, what can I do at home to help me here? So you're looking at a bath, you're looking at mobilizing, taking regular paracetamol like Heather said earlier, and using the TENS machine if you choose to use that. The one thing with the TENS machine, going back to the TENS machine, is that the earlier you start using the TENS machine, the better. You know, from the first contraction or those first little niggles of period pain, because the TENS machine works on an accumulative basis. So the sooner you start using it, the more endorphins you start to produce, which are your body's natural pain relief. So the sooner you can get that on, the better. There's no use putting it on at 10 centimeters or 7 centimeters, because you won't have time for those endorphins to build. You have to do that right from the beginning. So we then go on to the dihydrocodone and Oromorph. As we said on Friday briefly, in the latent phase, if you're struggling at home to distract yourself from the pain of the latent phase, you can come into the birth centre, into Broadlands or the New Forest Birth Centre, and have dihydrocodone or Oromorph just to help you through that early stage of labour. And you can go home after having taken those to continue your latent phase, to get yourself into labour at home, if that's what you choose to do. Going up one on the ladder is the Pethidine, and Pethidine is something that people need to have a little look at Pethidine, and you'll hear people say, I'd like to avoid Pethidine because it's an opioid drug that's given via an injection into your thigh. Here's a little bit of information about it here. The effects of Pethidine do actually transfer to the baby. It does. The molecules are small enough to pass through the placenta to the baby, and lots of people worry about that. What I can say is that if you have Pethidine, most of the time if babies are born 2 to 4 hours after the Pethidine is given, then babies tend to come out absolutely no problem whatsoever. What can happen occasionally is that the babies can come out feeling a little bit sleepy and a little bit tired, and sometimes that can affect the efficiency of your breastfeeding, of your first feed, because the baby is actually still a little bit sleepy from the Pethidine. So this is why we would suggest that the latent phase of labour, or very early in your first stage of labour, is the prime time to have Pethidine, if that's what you choose to have. It does have its benefits. Of course, if you've had a long latent phase and you're very tired and your body is very tired, and you just need to have a few hours sleep to regain that energy and refuel your body ready for the labour, then the Pethidine is a good thing to do. There are some side effects to Pethidine. Obviously, it's an opiate drug, and that can sometimes make women feel quite sick. But to counteract that, we generally give the Pethidine with another drug called Phenergan, which is an antiemetic, an anti-sickness drug that also has a relaxing benefit as well. As we've just said, if the Pethidine is given too close to the time of birth, then the Pethidine can make baby quite sleepy, and that can sometimes affect baby's breathing initially. They can be a little bit slower to start breathing regularly on their own. And as I said earlier, it can interfere with baby's first feed. So then going on to pool birth, obviously pool birth is a really fantastic form of pain relief. Lots of people really underestimate what the water can do for pain relief. Lots of people say, I had a bath, it wasn't that helpful, but the pool is completely different, okay? So the pool is deeper, so you have the buoyancy effect, it takes your weight so that you can move around and get into some really good positions that you wouldn't be able to on dry land. It gives you privacy, it gives you a space around you that nobody else can enter into, which can make you feel secure and make you feel secure and relaxed, okay? Obviously your birth partner will be with you, your birth partner can sit by the side of the pool, and actually sometimes birth partners do choose to get into the pool. What I would say is make sure you've got long shorts, no speedos are allowed. But some birth partners will choose to get into the pool. That would be completely personal preference. You just have to be able to get out of the pool quickly if the midwife asks you to do so. As I've said, it gives you really good mobility. You can really change into some good positions, and it's an amazing form of pain relief. Most women who get into the water do this kind of this relaxing sigh and just sink into the water, and it's lovely to see. And babies who are born in the water are generally quite nice and chilled out once they're born. We could go back to the ladder. Okay. So along with the birth pool, a really good combination in the first stage of labour is the birth pool and Entonox, the gas and air together. They are a really good combination to have. Can we go on to the gas and air? Fabulous. So this is a mouthpiece that you'll generally see. This mouthpiece they use at the New Forest Birth Centre. We have a slightly different one, but it's the same principle. The gas and air is a mixture, a 50% mixture of oxygen and nitrous oxide, and you breathe it in and breathe it out with the mouthpiece, okay? It's really important to learn how to use the gas and air properly. There's no point doing short little breaths on the gas and air. They've got to be long breaths that you breathe in through the mouthpiece, and then you breathe it all back into the mouthpiece, and it really regulates your breathing. And that's what lots of people find, that's the most useful thing. It just gives them something to control their breathing and a nice rhythm, which is really helpful to get through those contractions. You are in control of the gas and air, and it wears off as quickly as it builds up. So you're breathing the gas and air, and the effects of the gas and air are hitting you, if you like, and you'll feel quite lightheaded and a bit relaxed, and a little bit like having a glass of wine with a couple of puffs, which is a nice feeling when you're wanting to relax a little bit. The gas and air wears off as quickly as it ramps up. Takes about 15 to 20 seconds to build up and start working. So it's really important that you start using that gas at the beginning of your contraction, right the way to the end of the contraction. It can make people feel a little bit lightheaded, but the joy of the gas and air is if you feel that way and it's not making you feel very well, you can stop breathing on it. I tend to find actually that most people feel a bit lightheaded and a little bit sicky when we've started to use the gas and air a little bit too early. I tend to find that when people are really in the throes of labour and then start to use the gas and air, it tends to work a lot better and people tend to not be quite so sick with it. Some people just don't like the feeling of not being in control, and I think sometimes if the gas and air makes you feel a bit sicky and a bit lightheaded and not feeling quite with it or quite in the room, some people might not like that feeling of not being able to be in control. But like I said, with the gas and air, if you don't like it and stop using it, it wears off very, very quickly. There's no harmful side effects at all for you or your baby. The gas and air doesn't remove your pain. It kind of enables you to concentrate on the regularity of your breathing and just makes it bearable to get through those contractions. I think what's really important to be said is that these are contractions and they will come and they will go. One of the things that is most helpful when you're thinking about your pain is being able to relax in between the contractions. Because if you have a contraction and you're using all your energy, and then you're worrying about the next contraction when you're having that downtime, you're using even more energy. So the good thing with the Gassonaire is that it helps you relax during the contraction and hopefully will keep you nice and calm in between as well. And also the Gassonaire can be used with other forms of pain relief, such as the Pool or Pethidine or Remifentanil or an epidural as you're having an epidural. Right, we're going to go on to the big guns now. So the Remifentanil and the epidural. Both of these forms of pain relief are administered on our labour ward because we need to have an anaesthetist with us during this time. So Remifentanil is a really good alternative to the epidural. It doesn't work in quite the same way, and we'll go through that now. So the Remifentanil is a small cannula, a small drip that's inserted into your hand, and it's attached to a patient-controlled button, okay? So you are in control of the button. Starts working within about 5 minutes of setting it up, and what you do is a bit like the same as the Entonox. As soon as you start feeling the contraction building, you press the button and a bolus of Remifentanil is given to you via your cannula. The Remifentanil kind of takes you away out of the room a little bit, out to Outer Mongolia, and then when the contraction finishes, you come back to the room, okay? So you press the button every time the contraction is coming. There is a fail-safe on the Remifentanil, which means that it will only deliver a bolus to you every so often. It won't give you too much of the drug. So I think it's about 3 minutes. I think it times out, isn't it, girls? Can you confirm that?
I think it's 2 minutes, and yeah, it'll look out.
Yeah. So you can't give it any more than 2 minutes. So it's important to coordinate your pressing of the button with your contractions. That's really important, and your midwife can help you do that. The advantages of this is that you don't need to have your baby continuously monitored when you have Remifentanil. It makes you quite relaxed and quite sleepy. But in the same way with the Pethidine and the Entonox, if you are somebody who doesn't like not feeling in control or feeling a bit sleepy and a bit lethargic, Remifentanil might not be for you, but it might just help you relax to get you through those contractions. And each dose of Remifentanil will wear off. If you stop pressing the button, the effects of the Remifentanil will wear off quite quickly. Okay. So the disadvantages with Remifentanil is that it doesn't provide complete relief. So as with the epidural, 9 times out of 10, you can get a really good block of pain. But with the Remifentanil, it doesn't block everything. Most women do need a little bit of Gassonaire to feel comfortable whilst they're using the Remifentanil. And 1 in 10 women who use the Remifentanil will still go on to have an epidural. We have to observe your oxygen saturations whilst you're using Remifentanil, because the Remifentanil can make you so relaxed that it can affect your respiratory rate whilst you're so relaxed that you might not want to breathe so often. And that can sound very scary, but when you have the Remifentanil, you have a pulse oximeter on your finger the whole time, or your toe, and the midwife will not leave your side. She'll be watching the monitor, she'll be watching you. And if you've got very relaxed and didn't want to breathe so well, she will ask you to breathe. And it doesn't affect your ability to hear her and take a breath. And you will breathe. And that's why we have to be in the room all the time with you, giving you one-to-one care. Remifentanil can pass to your unborn baby, and it can cause drowsiness at birth. In much the same way that the Pethidine does, but it does wear off very quickly and has been proven to be safe for your baby. Common side effects are some women will feel nausea and will actually vomit. Again, we can give you an antiemetic, an anti-sickness drug that can reduce your feeling of sickness, and you can feel quite drowsy and quite dizzy. Lots of people actually sleep quite a lot when they're having remifentanil. Slow breathing may actually give you the need to have a little bit of oxygen via some nasal prongs that go into your nose. Just a small amount of oxygen can sometimes just keep your oxygen levels up. And having to stop using the remifentanil due to low oxygen levels or excessive sleepiness. So about 1 in 28 women will experience this, and then we would have to revert to a different form of pain relief. Okay.
What I like to say about Remi is that often, as you said, Amy, it sounds a bit scary when you say, oh,
Yeah.
you stop breathing. But actually, just to reassure those of you who may be thinking that, as Amy said, you have a midwife with you at all times. And all the women that I've looked after with remifentanil, it's had such a great effect on the pain levels that the women have been experiencing. Much more relaxed, much more capable of coping with the pain. Leading them on to, you know, progressing really well in labour, because it relaxes all your muscles, and obviously your uterus and your cervix have all got muscles in them, so it just really does help to relax your cervix and to, you know, aid with dilatation. So it is a really good one to think about. So please don't write it off just because we've said about the breathing, because we are by your side at all times when you're using that one.
Absolutely. And remifentanil does work really well for lots of women. And sometimes I think the advantage of having remifentanil over the epidural is that once you stop pressing the button, it wears off. You can get off the bed, you can go for a bath, you can handle your baby, you can walk around. And obviously with the epidural, it's not quite as simple as that. So lots of women do opt for the remifentanil because of the postnatal benefits of being able to move around. So then going on to the epidural. So the epidural is obviously the needle in the back that passes a plastic cannula into your back. Okay, lots of women sometimes say, you know, are you going to leave the needle in the back? There is no needle left in your back or any kind of cannula or anything like that. It's a very small plastic tube that is passed through the needle, and then the needle is taken away. So it's a very thin tube passed into your back, and it's a mixture of local anaesthetic and opiate-based drug that goes through the tube via a machine, and the machine works automatically. It's an infusion, so it gives you a dose of the epidural drug over a course of time. It continues going until we turn the machine off, so it doesn't usually wear off until the machine is turned off. It usually takes about 20 minutes for the anaesthetist to site the epidural, and it usually then takes a further 20 minutes for the epidural to really start working. Now, what's really important when you're having an epidural sited is the position that you are in when the epidural is being sited by the anaesthetist, because what needs to happen is that your spine, your vertebrae need to kind of open a little bit, and the way that we can most easily do that is to be sitting on the side of the bed with your legs up on a chair, with your feet up on a chair, and you make a C shape with your spine. So you're kind of bending over, you'll be hugging a pillow, and you'll be bending over the pillow to make an arch with your back. And by making an arch with your back, it opens up all the vertebrae, meaning that the anaesthetist will have an easier job getting in between and siting the epidural more easily. And the easier that part is, the more effective your epidural will be. The epidural can deliver fantastic pain relief. It can deliver a complete block of pain in labour from your belly button down, but it's not always 100%. It is affected by lots of different things. It is affected by the position that you're in when you're having the epidural sited, how still you can be whilst it's being sited. Sometimes the epidural can go off to one side, so one side of you doesn't feel any pain, but the other side is feeling some breakthrough pain. There are things that we can do about that. The anaesthetist will come back to review the epidural, and if it's not working quite so well, there are things that the anaesthetist can do to try and improve that for you. So when you're having an epidural, you'll need a cannula in the back of your hand that is attached to a bag of fluids, because when the epidural is sited, sometimes what can happen is your vessels dilate, your blood vessels dilate, and your blood pressure can drop slightly. So the fluids are there so that if that happens and your blood pressure drops a little bit, we can turn the fluids up a little bit and get your blood pressure up where it needs to be. You'll have a urinary catheter, because obviously once you've had your epidural and you are sat up in the bed, you won't be able to go out to the toilet. And as Heather said earlier, it's very important that we keep your bladder nice and empty. So the urinary catheter will be passed once your epidural is working. So again, your blood pressure will be checked every half an hour, just to make sure that that's nice and normal. And your contractions and your baby's heart rate will be monitored with a continuous monitor, because of course, once you've had your epidural, it's more challenging for you to be able to feel when you're having a contraction, and we need to know that the baby is reacting to the contractions as we would want them to. So the advantages of having an epidural: most women can have an epidural in labour. Epidurals do not pass to your baby, they don't make your baby drowsy. Epidurals can also be topped up if you were to need a cesarean section and you already have an epidural. Usually what happens is the anaesthetist just has to top the epidural up and you're ready to go for a cesarean section should you need one. The disadvantages of having an epidural is that it can slow the second stage of labour down. So when you get to the pushing bit where your cervix is fully open and your baby is ready to come, the sensation of feeling like you need to push will be reduced or may be reduced. And sometimes that's a bit difficult to know where to push and how to push. It can be impeded a little bit when you have the epidural. And there is a slightly increased risk of you or chance of you having forceps or a ventouse in instrumental birth, which we will be talking about in a couple of episodes' time. The instrumental birth, we'll talk about that in much more detail. But the likelihood of you having a cesarean section if you have an epidural is unchanged. It doesn't make any difference to having a cesarean section. So common side effects when you're having an epidural is that sometimes women will experience itching and shivering all over. Your back might be a little bit sore for a couple of days because obviously you've had the needle to put the catheter into your back. But the epidural doesn't cause long-term back pain at all. And a significant drop in blood pressure. About 1 in every 50 women who have an epidural may experience a drop in blood pressure, but we have the fluids there to be able to deal with that. So very rare side effects of having an epidural would be a severe headache. About 1 in every 100 women will have quite a severe headache after having an epidural. Nerve damage is also very rare. About 1 in 2,000 women will feel tingling or pins and needles down one leg. It's really difficult to tell whether that is because of the process of having a baby and the effects on the nerves of the baby going through the birth canal, or whether that is the effects of the epidural. It's very difficult to tell which is which.
Now, what I'm just getting up a website which we often recommend women to have a look at for pain relief. So this is latent.com. So this covers lots of information about pain relief. So if you go onto the leaflets part and go on pain relief comparison, what you'll be able to find there is all the different methods or options for pain relief. So gas and air, Pethidine, We got the patient-controlled analgesia, which is the Remifentanil, and epidural. And you can go down and just remind yourself the different points about it, and then that will give you a chance for you and your birth partner to have a little bit more of a discussion after this video about the different options. And there is also more in-depth information about epidural as well, so the risks are all there with the numbers. So please have a look at labourpains.com for some more information as well.
Yeah, the excellent thing about Labour Pains, the website, is that there are lots of different languages that information comes in as well. I know definitely working at the RSH, we've got a lot of women who maybe don't have English as their first language, but when we do talk about being involved in those decisions about your birth and about your pain, we want to make sure that everybody is fully informed with the information so they can make those really good choices. So that's another reason, as Laura said, why it's a really excellent resource to have a look at. And we have got that website printed in your notes as well. So if you're not sure and you haven't paused the video to make a note of that website, it is written in your notes around about your 36-week appointment, so you can have a look on there.
Now, what I just want to quickly show all of you is just the difference between these monitoring, just so you're clear. So the Sonicade here is the one that we use to do intermittent monitoring. So every 15 minutes in the first stage or every 5 minutes in the second stage, if everything is nice and normal and we've got no concerns about you or baby. Whereas this one on the left in the bottom is the CTG, which is for continuous monitoring of baby's heartbeat. And you can see here a little graph printing out. And what that graph shows us is lots of different aspects of baby's heartbeats that we are trained to look at and to interpret to make sure that baby is coping with the contractions. And these are the little probes here. So the green one attaches to your tummy to listen to baby, and the red one over here monitors the contraction frequency, which is printed on the bottom. Now, if ever you want a bit more explanation about the continuous monitoring, please just ask your midwife, because I know that I often like to explain what I'm looking at to my couples, because obviously it's happening to you, so it's important for you to know what I'm actually doing and what I'm looking at. So please don't hesitate to ask what it all means.
There was an extra form of monitoring that I've only just sort of been prompted to mention. So on the continuous monitoring, sometimes it is difficult to keep a track of your baby if they're particularly active or they're quite low down in your pelvis. One of the things, like Laura said, the factors that we're looking for on that graph is how well we're able, is there a good connection? Have we got a continuous trace that we can look at? And if we haven't, we might discuss with you something called an FSE, or a fetal scalp electrode. And this is a small electrical monitor that goes directly onto baby's scalp. So we administer it by doing a vaginal examination, applying it to baby's head, and then it plugs into one of the monitors on your tummy and then plugs into the machine. So that gives us a really, really clear view of exactly what's happening with baby if we can't get that external monitoring. Sorry, I meant to mention that earlier and I forgot, so that's why I chipped it in.
Brilliant, thank you, Laura. Heather, sorry.
Sorry.
Okay, I think that probably brings us to the end of episode 3. Any questions, as usual, please just write in the comments below or ask your midwife. So on Friday, we will be doing episode 4, which will be introducing the second stage of labour, which is when you will be pushing your baby out. I tell you one thing we haven't spoken about, girls, transition.
Oh, yeah.
We didn't talk about transition, and I said we would. So I will do that for you now. So as you are getting towards the end of your first stage of labour, you will start to feel a different sensation. You maybe will start to see a change in your behaviour. You might start saying things like, I've had enough, I'm going home, get me a taxi, or something like, this is all your fault, don't come near me again. And you start to change your behaviour and get a little bit feisty. Along with that, it can be quite scary, that bit, because that is just as your cervix is just slipping over the baby's head. So it is a feeling of almost panic. It's a rush of adrenaline and a little bit of a panic. It's not unusual. The midwives usually get quite excited when this is happening, because we're thinking, oh, this is it, the baby's coming. And then you start to feel urges to push, that pressure in your bottom. Lots of people relate it to feeling like they need to go to the toilet and have their bowels open. And that's that feeling of transition. And sometimes just before you go into that transition phase, you have this pause. It's called the rest and be thankful stage, we call it. And it's just a couple of minutes where you might not have any contractions and things are just nice and calm, and you're thinking, oh, this isn't too bad. And then you start to feel those urges to push and start to feel that kind of little bit of a panic. It's very important at that stage to just try to relax into it. Try to keep yourself in the game, to keep yourself in the zone, because that feeling does pass. That feeling of fear does pass as you start to go into the very productive feeling of pushing. Because when you start to go into the second stage of labour and you're pushing, everything feels just a little bit more productive. You're not sat there letting the contractions happen. You're actually physically pushing with them, and that feels very different. And that's what we're going to be talking about on Friday with you, the second stage of labour. Have you got anything else to add?
No, very much what you said. It's, yeah.
Lovely. Well, we shall look forward to seeing you on Friday.
As always, if you have any questions, please just write them in the comments section and we'll try and answer them as best we can. But I really hope that this video has been informative for you all. Thank you.
Bye.
Bye.